Welcome to this webinar, Capacity Building of Advanced Practice Nurses in Managing Patients with Cancer. This course is published by the University of Alabama at Birmingham School of Nursing, which is a Pan-American Health Organization and World Health Organization collaborating center. I'm Dr. Nancy Rudner. I'm on the faculty at the University of Alabama at Birmingham in the School of Nursing. Joining us in this webinar today are three faculty members who are experts in cancer care: Dr. Rebecca Suttle, Dr. Rebecca Edwards, and Dr. Richard Taylor. And you will meet each of them later on in the webinars. You will also meet some of the advanced practice nurses that are working in cancer care as they describe what they do in their role. By the end of this presentation, participants should be able to explain the role of the advanced practice nurse in oncology, survivorship, and palliative care. Should be able to identify patient care needs in the initial diagnosis of cancer, describe common types of cancer care modalities, and summarize advanced practice nurse interventions to manage cancer symptoms and treatment toxicities. First, let's look at the epidemiology of cancer, at the global and regional cancer patterns. Globally, as you can see, there are various types of cancer. The most common globally are breast cancer, lung cancer, and colorectal cancer. Lung and colorectal cancer are responsible for about 25% cancer deaths. In the region, breast and prostate cancer are very prominent, followed by lung and colorectal. But as you can see, half the cancers are from a range of different types. We know that cancer patterns differ by country. Looking at the top global map, you can see the incidence of cancers in males. The green is where prostate cancer is more prominent, and the blue is where lung cancer is more prominent. And then you can see some of the other cancers in the world. And below is the cancer patterns among women, where breast cancer is the most prominent, followed by cervical cancer. And then regionally, if you look at the age-adjusted incidence of cancer, these are the, how common is cancer? In 2020, on the left-hand side of the screen in blue is the incidence. And on the right-hand side in pinkish, reddish, orange is the death rate or the mortality rates in the Americas. We expect a dramatic increase in cancer by 2040. By 2040, we will have 28 million new cancer cases. That's a 47% increase from 2020. 20 years earlier. And we expect a 65% increase in Latin America and the Caribbean, because the increase will be most striking in the low and medium Human Development Index countries. The cancer burden will be highest in the high Human Development Index countries due to the growth in aging population and the increased prevalence of risk factors. But as you can see from this chart, all countries are expecting a significant increase. The nurse practitioner is one of the advanced practice nurse roles. There are multiple advanced practice nurse roles, and nurses have many ways in which they can assist patients and their families with cancer. The advanced practice nurse role in the United States developed in the 1960s. Building on a foundation of nursing. It started out as nurse practitioners providing well baby visits in the local health departments. Now, nurse practitioners are able to assess, diagnose, treat, prescribe medications, educate patients and their families, and provide support. The advanced practice nurse education includes what we call the 3 Ps: physical and health assessment, physiology and pathophysiology, and pharmacology, as well as other courses. But the 3 Ps are part of every program. And advanced practice nurse education programs are accredited nationally. Advanced practice nurses are a national certification. So they're certified nationally as well. However, their licenses are issued at the state level. There are 4 distinct roles of advanced practice nurses. I spoke about the nurse practitioner. We also have the registered nurse anesthetist, the nurse midwife, and the clinical nurse specialist. The World Health Organization has recognized that advanced practice nurses, quote, help countries deliver high quality, safe, affordable, patient-centered care around the world, end quote. We have more than 50 years of experience with advanced practice nurses. In the United States, there are over 100,000 advanced practice nurses, and the advanced practice nurse role has been implemented in over 70 countries. Nurses working in these advanced practice roles have had wide patient acceptance. We've had significant increase in access to care. And in 50 years, we have a proven track record of quality and safety. We also have specialties within the advanced practice role. The nurse practitioner with oncology specialty provides oncology expertise to patients and families and to the care team. This could be in the context of primary care or oncology care. The oncology specialty program includes clinical experience in oncology, as well as studying content and developing knowledge specific to oncology. These nurse practitioners with the oncology specialty may be employed in primary care clinics, in infusion centers that are treating patients with cancer, offices, and cancer practices. We also have nurse practitioners with palliative care specialty. Palliative care focuses on pain and symptom management, patient advocacy, and educating the patient and family caregivers. The palliative care nurse practitioner will collaborate with the palliative care team to provide holistic care. This is to promote quality of life and reduce the stress for clients and their families. These nurse practitioners may be employed in hospitals, clinics, home health care, long-term care, and hospice. So as you see, there are many different ways that advanced practice nurses can assist patients with cancer. We recognize, though, especially with the predicted increase in cancer, the need to have guidelines that take into account the reality of the resources available in each country. So oncology organizations have developed resource stratified cancer guidelines. With the increases in cancers, there's a need for infrastructure, resources to prevent, to treat, and to manage cancer. Otherwise, the increasing burden of cancers associated with socio and economic transition might overwhelm healthcare systems, especially in many lower income countries, if left unchecked. The Breast Health Global Initiative is dedicated to improving breast health care and cancer treatment for women in economically disadvantaged countries. So the Breast Health Global Initiative has defined best practices with limited resources, and they created consensus guidelines for early detection, diagnosis, treatment, as well as what healthcare systems should look like in public policy. And there's an implementation strategy for improving breast care cancer globally. So the guidance and the toolkits from the Breast Health Global Initiative are based on realistic resource availability for establishing and implementing comprehensive cancer prevention and control programs. We also have National Comprehensive Cancer Network Resource Stratification Guidelines, and that divides up the resource stratification to basic, core, and enhanced resources. There are also resource stratification guidelines, for example, in colon cancer. And these are available on the internet. The American Society of Clinical Oncology also has resource stratified guidelines. But this concludes part one. We look forward to having you join us in the next segment when we look at diagnosis and treatment for patients with cancer. Thank you.
Hello, everyone. It's Dr. Richard Taylor again from UAB School of Nursing, and I'm going to go over the navigation map of the cancer continuum just briefly. It'll be the sort of foundation or anchor that we use throughout the webinar. As you see here, there are multiple phases of or areas of the cancer continuum, and it begins with prevention and risk reduction, where we're talking about tobacco control, diet, physical activity, sun and environmental exposure, protection. And so that would be prevention and risk reduction for cancer. Then there's screening, where there are age and gender specific screening that would need to take place, like things like mammograms and colonoscopies, and genetic testing if the patient had a hereditary type of cancer. And those things would be in the outpatient or public health arena. Then we move into the diagnosis, treatment, survivorship, and end of life care. And these particular phases, as you see here, are as outlined. In the diagnosis, you would be obtaining biopsy, if possible, of the lesion or appropriate blood work to help diagnose the cancer. And you would look at the pathological report, the histological assessment of that to give an understanding of what type of cancer it was. And then there would be, once that was done, there would be additional staging that would need to take place, or including PET scans, CT scans, MRI scans, those types of things. Perhaps even more now with sophisticated blood work, biomarkers, and molecular profiling of the particular type of cancer. Treatment, systemic treatment, and we've talked about that, or we will shortly talk about treatment modalities, including surgery, radiation, other types of treatment. Then survivorship, when they move from the intensive treatment into a survivorship, that's where this particular cancer continuum is sort of set here. And then you would move into more surveillance for recurrences or screening for related cancers that might occur from radiation therapy or chemotherapy-induced cancers, and then genetics again here. And then end of life and the implementation of the advanced care planning. Obviously, we do not want to wait till this period here to really begin a advanced care planning discussion. That should really happen back here at the time of diagnosis. And end of life, obviously, if you have hospice available, whether that be inpatient or outpatient, and then bereavement care for the caregivers after the patient has died. This blue arrow here is indicating what should occur across all of these phases, and beginning with care planning, involving the patient. Goals of care, their values will help or should guide this whole process. And discussion or involvement of palliative care early is really the gold standard now. When the patient is diagnosed with cancer, palliative care should be involved early. Psychosocial support throughout this whole continuum, but particularly certainly important at certain phases of here, obviously the diagnosis, and when that is, really intense, emotional, not only for the patient, but for the caregiver. Thinking early about prevention and management of long-term and late effects, perhaps if the patient is a female and of childbearing age, or a male of childbearing age, then you would want to be thinking of management of long-term side effects. If the patient were to be infertile, then you would want to, here at the time of diagnosis, do sperm collection and egg collection. So don't forget that those things are really critical here at this point. And obviously family and caregiver support throughout the entire continuum. A cancer survivor is a survivor from the time of diagnosis all the way through. So that's just let's see here. So these diagnoses, treatment, survivorship, and end of life occur at inpatient and outpatient or inpatient. Obviously, if the patient is the inpatient and they have, at the time, they would get a lot of these things done. Oftentimes, the patient is put into treatment inpatient. So this occurs both in these areas here. And I just want to reinforce the fact that palliative care or supportive care should begin here at the time of diagnosis. So that concludes my brief introduction of the map. And so we will use this throughout the webinar to sort of anchor our presentation. Thank you.
Hello, everybody. It's Dr. Rebecca Edwards, and I'm going to go through the section on outpatient cancer diagnosis. So where are cancers diagnosed? They're diagnosed in many different types of outpatient healthcare settings. This can be in hospital-based clinics, in community-based clinics. It can be in a nursing home or a skilled rehabilitation facility. Can be diagnosed in any kind of specialist outpatient office, such as obstetrics and gynecology offices. This would apply to, again, any specialist office, such as cardiology or pulmonology, et cetera. So what leads to a cancer diagnosis? If cancer screening is available, oftentimes a cancer screening process will lead to a cancer diagnosis, such as a colonoscopy, PSA or prostate-specific antigen blood test, a mammogram, and a variety of other cancer screening procedures. I know oftentimes that's not fully in place in some regions, but for most places, cancer screening is available, and this certainly can lead to a cancer diagnosis. And the good thing about cancer screening is that when cancers are diagnosed, they're typically diagnosed at an earlier stage and are much more treatable, and people do better when cancers are diagnosed on screening sometimes, but not always. But the whole point of cancer screening is to find cancers at an earlier stage so that the outcomes are more positive and prognoses are better. Certainly cancers can be found incidentally. So just say, you go into a primary care office or a community clinic with a cough, and you have a lung x-ray, and a nodule is found on that x-ray, such as in this image. Also can be incidentally found on blood work or lab tests, such as finding elevated liver function tests, or certain enzyme markers, or certainly hematologic findings for leukemias and that type of cancer. So these can be found incidentally just on blood work that would be drawn and analyzed for routine primary care purposes. Providers can certainly find cancers on physical exam, or even based on a review of systems. So if you're an advanced practice nurse and you palpate a nodule, for instance, if you're doing a good lymph node survey, or if you hear some adventitious lung sounds, or any other abnormalities that are found on physical exams, such as skin findings, melanomas, other types of skin cancers, any lumps and bumps that are unusual, that would be followed up with imaging studies or biopsies, et cetera. So that would be one way that providers would find cancers. Also in the review of systems, if somebody states that they're having unusual symptoms, such as dark urine, or itchiness, or any other review of systems finding that would lead to a cancer diagnosis, certainly would be a way that advanced practice nurses and other providers would find cancers. That can lead you down a trail of looking for a cancer based on the review of systems. And also patients or even family members can find cancers. Patients or a family member might notice a skin lesion, or they might notice a lump or a bump somewhere, such as in a breast cancer or a lymph node that's unusual in the inguinal area or somewhere else. Also can be things like, unexpected weight loss, and other pains and discomforts that can lead to a cancer diagnosis. So how are cancers diagnosed? So certainly, once you suspect a cancer, there would be routine blood work and potentially fluid lab tests. Just say that you suspect, based on pain, that a person may have a pancreatic or a biliary cancer. You might do a special tumor marker, such as a CA19-9. If you suspect a colon cancer, you might do a CEA. And there are certainly other blood tests that would lead to the cancer diagnosis. And there's a multitude of those. If somebody, like a gentleman, comes in and complains of difficulty urinating, hematuria, poor flow, interrupted flow, a PSA may be drawn and may be very high, and that can lead to a prostate cancer diagnosis. Certainly imaging is a big part of diagnosing cancers. This can be anywhere from plain films or x-rays to CT scans, to MRIs, to PET scans, to bone scans, ultrasounds, et cetera. So imaging is a key component to looking for cancers. A cancer is never definitively diagnosed until cancer cells are detected in a tissue biopsy or even a fluid biopsy. So this can be cytology or pathology. So even though you may see a nodule or see a mass on imaging, until you actually have that tissue biopsy and pathology has been carried out and a cell type has been determined, there's never truly a cancer diagnosis that is definitive. Also, more and more in our current culture of diagnosing cancers, biomarker panels and other special tests have become very, very important for diagnosis, as well as, excuse me, I apologize for that disruption. So let's move on here. So in terms of, the cancer diagnosis, for all cancers or most cancers, all cancers really are staged in some way. It may not be in this type of a staging schema, but most cancers are staged as stage 0, 1, 2, 3, or 4. And the earlier the stage, so stage 0 or 1, has a better prognostic outlook than would the later stages, stage 3 or 4. In stage 0, they have found abnormal cells that may be dysplastic. They may be limited in terms of not having grown outside of the area where they started to grow, which is termed in situ, and not really considered a cancer yet, but on its way to being a cancer. The probably most common example of this would be a colon polyp that is removed on colonoscopy, which is really the whole purpose of having a colonoscopy. might be also a very early dysplastic change in breast tissue that would be removed with a lumpectomy. And that should be that. There should not be any real risk of cancer development from that particular site. Stage 1 cancers are usually contained and very small. They're usually within an organ, such as a lung nodule or a breast nodule or a prostate nodule or a thyroid nodule, et cetera, that can be removed with clean margins. And most people do really well after that and are at relatively low risk for any recurrence. Stage 2 has not spread outside the surrounding tissue, but is larger than a stage 1. So usually there's some sort of measurement criteria that would move from a stage 1 to a stage 2 if it's bigger, and that's usually in millimeters. Sometimes stage 2 means that cancer cells have spread into lymph nodes close to the tumor. So for a breast cancer, that may be, axillary nodes, for instance. In stage 3, the cancer is large and may have spread into surrounding tissues and lymph nodes in the area. And in stage 4, the cancer has spread through the bloodstream or lymphatic system from where it started to a distant site in the body, and that is termed metastases. So as you get towards the later stages, particularly stage 4, the prognosis becomes much shorter and people don't do as well generally. So, what happens when patients are being moved through this process? So there's usually an interprofessional cancer care team involved in the US at least, and in other settings as well. I think in probably most of your settings, but this may not be the case in some regions. So the specialties are, that are involved with an interprofessional cancer care team are medical oncology, who are typically involved with the systemic treatment of cancers, such as chemotherapy or different biotherapies, immunotherapies, et cetera, targeted oral agents, that type of thing. And then surgical oncology, who would go in and remove any cancer surgically, radiation oncology to try to localize radiation effect to a tumor or to a region, and pathologists who are also involved with determining the exact pathologic makeup of the cancer itself. And the specialists who are usually involved in these interprofessional cancer care teams are physicians, advanced practice nurses, physician assistants, and nurses. And I would say that as a general rule, but not always, advanced practice nurses tend to be more in the US involved with medical oncology and radiation oncology. Some are involved with surgical oncology, but not as many as physician assistants. Physician assistants tend to migrate towards the surgical oncology aspects of cancer care. So on the left here, the diagnosis occurs, there's treatment planning, there's treatment, and then surveillance or follow-up. And one thing that I can't recall is if it's on a future slide, so I'll mention it here, is that oftentimes patients are navigated through interprofessional clinics where they may see multiple cancer specialists, such as the medical oncologist and the surgical oncologist in one visit, or all three, medical oncology, surgical oncology, and radiation oncology. And this can be a very comprehensive kind of day for a patient and their family members or caregivers, where they're seeing, a multitude of people, physicians, advanced practice nurses, physician assistants, nurses, and the sense of being overwhelmed in those types of clinic situations, is pretty substantial. And it's got its benefits because people can get navigated through all of those processes in a single setting, which is lovely for people. So it's much more convenient, but it can be kind of an information overload at times. And also, I need to make mention that these interprofessional teams often sit in, committee type settings in a conference room with a large screen and projection, and have the ability to work through a patient's case, which would include looking at imaging, looking at pathology, looking at special stains, talking through radiation planning, talking through medical oncology planning, and navigating that whole treatment planning process in something that we would typically call a tumor board. So that's an important thing to think about, where advanced practice nurses are integrally involved in maybe presenting, cases in those settings. So for instance, when I worked in medical oncology at Yale in Connecticut, I was often charged with presenting new patient cases and then talking through with the physicians and the physician assistants and the specialists, how we would move a patient through their treatment planning. And of course, we would bring things up like psychosocial issues and any family issues, financial constraints, insurance issues, and all kinds of different pieces to the puzzle. So I should mention that our social workers, which I didn't list as a specialist here, are typically involved as well. And there may be pharmacy representation, if there's certain drug related questions that need to be dealt with during that tumor board. So the advanced practice nurse involvement really is diverse. I would say that the role I would define as coordinating, communicating, and direct patient care in the green circle here. And that can be, from a primary care perspective, where the advanced practice nurse might be the person who's seeing a patient who has a potential new cancer diagnosis, or found, the lump or bump on a physical exam, or noticed that something in the review of systems was not quite normal. So it may be in that primary care type setting where the nurse practitioner or advanced practice nurse is initially involved. It may be in cancer care, which was my area, where we would see the patient once they had a cancer diagnosis and would be navigating them through, their treatments and follow-up, et cetera. Maybe in radiology, particularly in interventional radiology, we do see several advanced practice nurses in that setting in the US where advanced practice nurses may be doing interventional radiology procedures such as biopsies or things like, trying to get symptoms under control, like celiac blocks and other nerve blocks, things like that. So advanced practice nurses are certainly integrally involved in radiology as well as in the surgical area, where they may be seeing patients for surgical planning or follow-up and pain management after surgery, et cetera. So what can happen that would be barriers to cancer care? There's so many things, and it really would be dependent on the setting. But on the top layer here, you'll see the yellow box that says clinician. And the clinician, across these squares on top of this, this figure, would be involved in making sure that they are approachable, that there's transparency in the information that's being delivered, that they're coordinating or helping with outreach if that's needed, making sure that they're being ethically sound and professional, and taking culture and gender and all kinds of different variabilities into account when working with a patient and their family or caregivers. Must think about geographic location. Do people need accommodations? Are there different hours of opening that would be meaningful or limiting to patients and families? How can they get their appointments scheduled? So you don't want delays in appointments if a patient is dealing with a cancer. So you want to be available and accommodating. Is there, issues with affordability, insurance coverage, cost of chemotherapy or immunotherapies, cost of oral drugs. And this can be very time consuming and difficult, and advanced practice nurses tend to be very much involved with that along with social work. Are there technical and interpersonal quality aspects that need to be considered? Are we adequately coordinating and making sure that there's continuity in care? And the advanced practice nurse is very much involved in all of this. And on the bottom, the patient may have, barriers such as health literacy. They may not understand, may, be illiterate, may not have the same health beliefs that their providers have. They may have mistrust of providers, including advanced practice nurses. They may have certain expectations that are, different than the provider anticipates or perceives. They also have, different personal and social values. Are they able to seek care appropriately? Are there cultural issues, gender issues, autonomy issues? They may have difficulty with access, ability to reach their healthcare center, ability to reach their providers, including the advanced practice nurse who often fields many of these phone calls and visits. There may have, living environments that are not really conducive to, dealing with a cancer diagnosis. They may have transportation issues, mobility issues, and inadequate social support. And then the income, may be an issue. And again, health insurance and having too many assets to qualify for free, drug, things like that, that can be very difficult and make it a barrier to being able to get adequate treatment. And do they have the ability to engage? Do they feel empowered? Do they have the right information? With our information age, patients and families come in with lots of information that they feel they can trust on the internet, but it may not be reliable, evidence-based information. Do they have the right caregiver support? So the barriers to cancer care are significant for some, and this all needs to be considered, particularly in lower resource environments. So what causes delays in cancer diagnosis and treatment? And I know this can be a substantial problem in low resource settings. So if a person has a first symptom or there's some sort of a perception or idea that they have a potential cancer, their first visit to the doctor can be very delayed. Their diagnosis can be delayed. It may be that they've made it to the physician's office and they can't get a biopsy, or they get the biopsy, but the pathology takes, a long, long time to come back. And then once that diagnosis is confirmed, when they get their first treatment may also be delayed. They may have a poor awareness. They may have financial barriers, logistical barriers, psychosocial barriers. And, if they have a poor performance status and it's hard for them to get around, that's also potentially problematic. There may be waiting lists, there may be suboptimal resources. And all of these things can cause access delays, diagnosis delays, and treatment delays. So these things need to be considered, because when one is diagnosed with a cancer, delays can be very difficult emotionally. They also can be very, they can contribute to a poorer prognosis, because if a cancer is rapidly growing and these delays are substantial, what may have been an earlier stage cancer may become a later stage cancer, and then the prognosis becomes worsened at that point. So one thing I just wanted to mention, and advanced practice nurses are certainly involved with this process, is prognosticating. And this is becoming a much more complex thing to do when patients are, being prognosticated for different cancers. And the reason for that is that our treatments have advanced so substantially and so quickly, particularly with the advent of immunotherapies and targeted therapies, that what used to be kind of easy to understand in terms of how long a patient would live with a certain stage and type of cancer has become difficult, because the treatments are so different and are somewhat personalized, and we don't have all of the information at this point. So we can say that certain patients will do so much better than they would have with standard chemotherapy if they're given immunotherapy, or combinations of immunotherapy and chemotherapy, or a combination of radiation and immunotherapy, targeted therapies, et cetera. The treatments have become so much more sophisticated that prognosticating has become much more difficult. So There are prognostic tools that can be used, and advanced practice nurses need to be aware of those. And I just wanted to make mention of this without going into too much detail, but I would highly recommend that if you are practicing as an advanced practice nurse, to look into how to prognosticate. And this also becomes very important for patients who are considered late stage in terms of their cancer, and maybe be approaching, end of life and potential for end of life type of care. Thank you so much, and I hope that this section of the program was very helpful to you.
We will now talk more about how the inpatient setting and APNs in the inpatient setting can play a role in the care of oncology patients. We'll go back to the care continuum. You can see here on the care continuum that the inpatient setting does play a role in the care of patients with cancer, most often at diagnosis and during treatment for various reasons. There are three major reasons why oncology patients may be in the hospital. This can include emergencies, treatment purposes, and for complications from the treatment or the cancer itself. The APN often plays a role in the inpatient setting, managing these types of admissions. The role of the APN here can include management of various aspects of the inpatient stay, including the diagnosis and workup, as well as emergencies and complications. And very importantly, the APN often plays a significant role in the coordination of care for a patient who's in the hospital. Let's talk more about the reasons an oncology patient may be in the inpatient setting. As far as emergencies go, patients can present with oncologic emergencies prior to diagnosis or can present with these while undergoing treatment, most often at the initiation of treatment. These can include, but are not limited to, tumor lysis syndrome, hypercalcemia, superior vena cava syndrome, febrile neutropenia, or spinal cord compression, for example. Many of these emergencies do require inpatient treatment. The patient may also present with new acute signs or symptoms that require evaluation in the emergency room at diagnosis, at initial diagnosis. These evaluations can lead to an inpatient admission if the signs and symptoms that the patient's having indicate that that's necessary. As far as treatment goes, some treatment regimens may require inpatient treatment, either for the initial treatment or even sometimes for many cycles of treatment, the cycles that follow the initial therapy. So for example, a diagnosis of acute leukemia would be treated, or if it's treated with standard therapy, for example, these types of patients would require admission to a hospital, both for close monitoring of the infusion, as well as monitoring for the common and life-threatening complications that can occur during and after these infusions. High-grade lymphomas, such as diffuse large B-cell lymphoma, are also treated inpatient often. This depends on the chosen treatment, of course, and the risk level of the patient as far as their tumor burden and location of tumor is concerned. Some treatment regimens that require specialized lab monitoring or other regular types of patient monitoring may require an inpatient admission as well in order for these tasks to be completed. Clinical trials at times, particularly phase 1 trials, may require some level of inpatient monitoring due to the experimental nature of the treatment. And stem cell transplant, particularly allogeneic transplants, are often done in the inpatient setting, as these require much closer monitoring of patients for reactions and other life-threatening complications that can occur. As far as general complications, patients who are undergoing active treatment as an outpatient, which is the case for most cancers, are at a high risk for treatment complications or toxicities. While many of these can be managed as an outpatient, some are refractory to these outpatient management steps and require that the patient be admitted to the hospital for acute management. An example of this would be nausea and vomiting that is unable to be treated with oral medications in the outpatient setting. So these patients may require an inpatient admission for IV fluid and IV antiemetics. At times, the cancer as we know, will not respond to the treatments that are offered. And patients may experience symptoms of cancer progression and ultimately may even experience failure to thrive. These patients may be admitted briefly for acute management of their problems or stabilization of these problems, while discussions are led by the medical team surrounding goals of care and end-of-life decision-making. So let's talk more about the role of the APN in the inpatient setting as it relates to patient care. The role of the advanced practice nurse in the inpatient management of patients with cancer is multifaceted and can be comprehensive in nature. APNs can manage all aspects of an inpatient stay, from the admission, completing a comprehensive evaluation with a creation of a medical plan and placing admission orders, to the treatment of the patient, managing the day-to-day decisions that have to be made, documenting the progress notes, prescribing drugs, and ordering nursing care as indicated for the patient, as well as consulting other specialists for their expertise. To the discharge of the patient. This could include discharge orders, discharge summary documentation, prescriptions, again, medication reconciliation, and patient and family education that may need to be completed at discharge. The advanced practice nurse can also enter transfer orders for the patient if the patient needs to transfer to another level of care within the hospital, or can facilitate a transfer to a larger regional facility that provides the necessary resources for the patient, although this type of transfer is more often led by physician colleagues. As far as the diagnosis goes, the advanced practice nurse can play a role in the initial diagnosis of the patient when they are presenting with symptoms of cancer. While a workup is more often done in the outpatient setting, like we've discussed, there are certain cancers, such as acute leukemia, an example already given, that may require an immediate workup and start of treatment that the inpatient advanced practice nurse could be involved with. In the case of acute leukemia, for example, a bone marrow biopsy is typically done, and this procedure can be performed by an advanced practice nurse. Oftentimes, the physician team leader will be the one to discuss pathological findings with the pathologist and perform more advanced diagnostics, such as reviewing blood smears and interpreting molecular findings or other specialty lab work findings. The advanced practice nurse may do this as any of these steps previously mentioned as a part of the primary team, if they're a member of the primary team that is managing the patient, or as a consulting team, lending their expertise maybe to a general hospital medicine service, if they are the ones providing the primary care for the patient while they're in the hospital. As far as management goes, advanced practice nurses in the inpatient setting also manage the day-to-day care of the acutely ill patient, as we've mentioned before, whether this be in the emergency room or in the unit after a patient is admitted, an acute care unit or a critical care unit. Patients who present to the emergency room or have an oncologic emergency while already admitted do require immediate and attentive care. Advanced practice nurses can provide this by identifying the cause for the emergency and treating it as quickly as possible, again, whether they're part of the primary team managing the patient or as a consulting expert within the hospital. Advanced practice nurses who are managing the day-to-day care of admitted patients see the patient daily, document their progress, and change the plan of care as necessary in cohort with the physician who's leading the team, of course, and consult with the physician who's leading the team, of course, and then ultimately plan for discharging the patient from the inpatient setting. Managing the daily care of the patient involves evaluating the patient daily to measure their response to already completed interventions and creating a plan of care for that day. The plan is enacted by the nurse practitioner entering orders, and throughout the day, the nurse practitioner or advanced practice nurse will follow up on the patient to ensure they're doing well and responding to the interventions that have been completed. Patients who are admitted to the hospital due to treatment complications are often very sick and need advanced imaging, IV therapies, and close monitoring, all of which the advanced practice nurse can order, follow up on, and manage. The advanced practice nurse often plays a significant role in coordination and transition of care. Often APNs are leading the coordination of the patient's care. This may consist of the APN being the point of contact for the interdisciplinary team while the patient is in the hospital. It may mean coordinating the care of the patient as they leave the inpatient area and return to the outpatient setting or to a skilled nursing facility for continued physical rehabilitation if that's needed. This may also mean coordination of hospice care if the patient is nearing end of life and hospice care is indicated.
My name is Mary Therese Callens, and I am a nurse practitioner at the University of Alabama at Birmingham, and I work on the Hematology Oncology Specialty Unit. I work as part of an inpatient team that cares for patients with hematological issues such as leukemias, lymphomas, multiple myelomas, and other hematological issues. I am a member of an interdisciplinary team that includes physicians, other nurse practitioners, physician assistants, case managers, social workers. We all function together to take care of patients from the moment they are admitted to the hospital, manage them through their hospital course until the time of discharge. Oftentimes, patients may present to the hospital with nonspecific symptoms such as fatigue or weakness, and may be delivered a life-changing diagnosis such as acute leukemia or lymphoma. It is my job to see these patients from diagnosis through treatment, such as chemotherapy, and deal with comorbidities, including oncologic emergencies like febrile neutropenia, tumor lysis syndrome, and DIC. I graduated from nursing school in 2001 and worked at the University of Alabama at Birmingham Surgical Intensive Care Unit until I transitioned into the nurse practitioner role in 2009. While I love the intensity and acuity of working in the surgical intensive care unit, I was ready to transition my role into more of a diagnosis and treatment. I have always had a special interest in oncology, and to be able to go to work every day and work with patients with cancer is so rewarding. Working for a public institution such as UAB, we get patients from all walks of life. It is our job to care for every single patient, regardless of their socioeconomic status. For instance, I once had a patient that was a young, uninsured single mother of 2 young children. And when she came to us, we gave her the diagnosis of acute myeloid leukemia, which is a life-changing diagnosis. It often involves people getting very sick and having a prolonged hospital stay. Not infrequently, people can be in the hospital for up to 30 days. And my care of her involved delivering this diagnosis, explaining it to her, being involved with her chemotherapy, and also, in addition to medical management, was having to help a young lady through not being able to see her children for a month, to figuring out how to transport herself back and forth to the hospital every week for labs. If I could offer one piece of advice to a new oncology nurse practitioner, is to always advocate for your patient. Throughout your career, you'll be presented with challenges and decisions where you might not be sure of the right answer. The right answer is to always do what is best for your patient every single time. In the end, the patient isn't going to remember what medications and what labs you ordered. They're going to remember that you cared for them and every single decision you made was in their best interest. A day in the life of a nurse practitioner is I get there early in the morning and I sit down and look at my patients, review vital signs, lab work, any diagnostic testing that had been done since the last time I saw them, and formulate a plan for the remainder of the day. I enter orders. Then we have a meeting, a multidisciplinary meeting later in the morning where the whole team gets together and discusses more in depth a plan of care and addresses the other team members' needs, such as social workers and barriers to discharge, like transportation issues or lack of insurance, and how we can, as a team, overcome these barriers. Then the team meets and we round room to room. The team at this time includes the attending physician and the nurse practitioner. We go into each room and speak with the patient, do physical exams, address any concerns of the patient and the family, and make a more detailed plan as needed. So we continue to do this until we've seen every patient on the service. And when rounds are complete, I go back to my office and enter any more orders that need to be entered, such as chemotherapy, electrolyte replacement, labs that need to be drawn. And during this time, I'm also taking care of admissions, patients that are new to the hospital, and discharging patients, all intermingled with speaking with nurses about any concerns that they may or may not have.